what's in there, and also about what is in the state of the art. But you'll see that it's pretty primitive. Having said that, as an addictions doctor, we're really accustomed to working in the primitive, preclinical stage. But we still have the problem. We still have to treat the person. And we're going to work with maybe not necessarily peer-approved research. Of course, build that as we can. But in the meantime, we have to continue to work. In the 1980s, people talked about cocaine as not being addictive, and the research did not prove that it was addictive. But we addiction doctors said, well, it doesn't really matter what you say. We see it, and we're going to treat it as if it is. And there we go. So that's sort of the state of where we are. We have this a slogan here for today: eat less, eat better. Is it that simple? I want to suggest, yes, it is that simple, but it's not easy. And this is a phrase we see here in addiction all the time. It's simple, but it's not easy. You just stop the addictive substance. And I will talk more about that. So now, do I know how to do this? Okay, maybe you can just help. Yeah. Oh, there we go. Okay. And if I want to go back, yes. Okay. So I would like to suggest that having the message of food addiction as a dynamic for at least a small proportion of the population in terms of being really clinically addicted, but then also underlying, because we are all compelled. Everybody, when they have a marshmallow, from a bag of marshmallows, will probably want 2 or 3. It's going to be hard to stop at 1. So even just understanding addiction from a general point of view, not even as addicts, but addictive, is useful information to have. I want to address the concept of, does food addiction exist? And then suggest to you that if we start acknowledging the external dynamics and also psychological dynamics, then really the whole idea of obesity becomes less stigmatic, because we're dealing with a medical condition. Okay, so these next few slides you've all seen before. You know this, the BMI is increased, and why is that? Because we're assuming, and why do we care? Well, we're here at a conference like this because it affects the body and health, and is tremendous healthcare consequences. When we talk about why it is that we overeat, because that's essentially the message, there seems to be 2 messages that we hear in the general population, and then food addiction, as I said, is a little bit of a side, that faddish kind of message that is becoming more popular now. But the first one is I guess this idea here: eat less, eat better, exercise more, and you'll be good. Just stop. And this is the message that we, for the most part, use, maybe not consciously, but we use when we suggest that somebody go to Weight Watchers or go on a diet and then learn how to eat well. That if they're not doing so, they just need to learn those self-will tools. And then if a person moves, and if they go to Weight Watchers or they go to Jenny Craig or something like that, and it works, then we would say, great, this is a normal eater who is occasionally gluttonous. We may not call it, but that's sort of the implication. If a person comes and says, no, there's something else happening, and they sort of go to a medical realm, medical doctor, psychiatrist, nutritionist, what will most likely happen is that they will also have I'm just going to jump ahead here. They will most likely be then steered to the other potential diagnosis, if it's not sort of just poor willpower. Is this an eating disorder? And so bulimia would be an obvious potential diagnosis, and now binge eating disorder as a second, fairly new one. And just to point out, you see that the next line, blaming the victim, both of those, the sort of moral, can you just get it together and stop eating, or you've got a food binge eating disorder, potentially put the focus on the patient, and very little goes to the food industry, which I would like to suggest that when you see either an older man like that or a young child, is this gluttony, is this a binge eating disorder? No, I don't think so. It's food engineered to be addictive. Okay. So why do we care? Well, that's the politics. I just want to go back to just say something about binge eating disorder. The whole concept of food addiction, does it exist? We believe that it does. Addiction doctors are sort of getting on board. When I came into the field of addictions in the mid-90s, I became aware of how people were eating when they stopped their drug, either cocaine or alcohol, that all of a sudden they were eating much more than they ever did before. And it kind of clued in my mind, there's something addictive happening, but I couldn't find any reading or research that supported that. And certainly nothing in the DSM-4 at that time. And in the DSM-5, which you probably know came out a couple of years ago, binge eating disorder was acknowledged, and that was good news. Food addiction was not yet acknowledged. And the food addiction advocates that were in the field spoke, I mean, I don't know if you know this, but the DSM is a very political process. You have to lobby, you go down to the states, and you go to committees, and you have all your research and state your case type of thing. And the food addiction advocates were there with their papers, many papers, and said, okay, here, can you go with this? And what happened is and so did binge eating disorder, they got in, and then we got the letter, the people who are doing the advocacy, got a letter, which I actually saw a copy of, that said, this is all very interesting, food addiction. We're not saying it doesn't exist, but we're saying we need more research, and we need more research to show how it's different than binge eating disorder. So go out there, and maybe when the next DSM-5 or 6 or 5R or 6 or something comes out, maybe we'll think about it again. So we're in the middle of the process. We're not there yet. So state of the art with diagnosis hasn't been diagnosed. It's been approached. And in the meantime, clinically, we are in a kind of no man's land. In the US, you need to have a diagnosis from the DSM-5 to get insurance, to get research, to get medication. It's very important. In Canada, and also just for acknowledgement. And in Canada, not so important, but very little acknowledgement. But nevertheless, clinically, we see this more and more. Why do we care? For example, the difference between a binge eating disorder and a food addiction. They look the same. I'm actually going to show you some questions. They really look the same. So why do we care? And aside from the fact that one has an implied redirection of criticism from, yeah, I'm eating addictive foods, but if I weren't eating those foods, I wouldn't be so compelled. It's just the same as people smoking. If you're in an environment where cigarettes are there all the time, and the norm is it's all good, people are more likely to pick up than not. So there's that piece, but there's also the solution is entirely different. If you're taking a food addiction framework, you identify the triggering chemical that is in your body that is making you what we call develop an obsession or a phenomena of craving, so that you want to crave to eat more and more of that. The simple solution, it's simple, stop eating that substance. That message of abstinence, just to that trigger food, is quite revolutionary, and probably, as I said, potentially could fit into that fad category. And I'd be really eager to pull it off of the fad category and just make it part of the table of options that a clinician might use for a person that's struggling in front of them. Just consider it as an option, and that option being abstinence. So let me first of all talk about what we're dealing with. So the state of the art, that's basically this message here, is if we can start to acknowledge food addiction, we can actually, I think, then start seeing less stigma and less blame towards the person. Asking for a new paradigm. Let's see foods, particularly, I mean, this is not all foods. People say, Dr. Charman, but you have to eat. You have to eat 3 times a day. It's the same as the alcoholic who says, yeah, you have to drink water. Yes, you do, but you don't have to drink alcohol. So you have to eat, but you don't have to eat processed foods like sugars and white flours and all the rest of that. There are plenty of dietary options that are the F&Vs. That are totally fine to eat. We're talking about foods that have been engineered to be highly palatable, and for some people triggers that phenomena of craving so that they can't put down their fork. even when they want to. I'm full, I want to stop, but no, I don't want to stop. New paradigm. This is a picture that accurately describes my day every day in the office. The one line over there, it's the rehab, drug rehab center. People not doing their alcohol anymore, not doing their drugs, but instead going for the food. And then when I started seeing that in the general population as well. Not for everybody, but a number of people. Oh, there's something funny about their relationship with food. Now, what is that, and how can we measure that? So then we move into the concept of diagnosis, as I said. How have we been able to diagnose food addiction? I'm giving you a state of the art. And again, I want to remind you, we're in preliminary stages as far as research and science goes. Concept of food addiction has been around since the 60s, 70s in the public press. You know, you'll see books like Sugar Blues, Sugar Toxic, you know, a whole bunch of stuff. OA, Overeaters Anonymous, started, I think it was 1960, already right from the get-go, talking about compulsive eating and food addiction. So it's been around for a while. The way that it has been used, I'm just going to show you some of the questions, and you'll actually see how similar they are to binge eating and other stuff. So these are standard questions. It's like the 20 questions for are you an alcoholic? Here are the 20 questions for food addiction. And it's just a few of them. Okay, so have you ever wanted to stop eating and found that you couldn't? Like I said, it'll look like binge eating in some ways. Have you ever thought about food or your weight constantly? Do you find yourself attempting one diet after another with no lasting success? Do you binge and then get rid of the binge? Do you eat differently in private? Do you eat in secret? Now we're starting to look at behaviors that are suggestive of addiction. Do you eat large quantities of food at once, or do you restrict? Now, you could see that as anorexic and bulimic type behavior, or you could see that as a person who's trying to quit their drug, quits, and then goes back and uses again, relapses. Have you ever hidden your food to make sure you have enough, so you don't have to share it with somebody else? Have you ever stolen somebody's food, other food? Have you ever thrown away food and then gone back to eat it again? Have you ever felt hopeless about your eating behavior? Nothing will work. We have attempted to standardize what is food addiction with a tool called the Yale Food Addiction Scale. It's based on the DSM-5, and it actually got peer approval, I think about 5 years ago, as a clinical tool. It's our first one. So in that sense, very good news. And when you have a standard tool like that, as you know, not only can clinicians speak the same language across clinics, but also we can start looking at research and know that we're measuring the same thing. So this is good news. It's unfortunately, at this stage of the game, very cumbersome to score, so it's not used that often. However, it's in the works, and people know that it's not. Even the person who designed it, Ashley Gearhart, has kind of shrugged and said, I know it's a research tool, I'm a research psychologist, I'm not a clinician. So we're trying to figure out how to make it more workable. But at least it exists. In the meantime, a lot of us in the addiction field who are inclined to accept that this might be a true diagnosis, we use our own addiction tools. You know, we follow the DSM-4, now 5, and use those tools. I like to see it as the ABCDEs of addiction. Just very quickly, are you able to A, abstain? I'm trying to quit smoking, I quit. I'm trying to quit eating, and you quit. Usually people can't. They are, I'm going to stop eating this way, and then before you know it, at night, they get home and they pull out their Haagen-Dazs tub again. Can you control behavioral control? B, can you control your behavior? Can you have one and stop at, well, not maybe one, but 3, as opposed to, I've just started the bag of cookies, I should be, okay, I'll finish the whole bag because I really want these, and then, oh no, I still want more, and I don't know what to do, but I'm going to go and get some more, and the control around that behavior is lost. C, cravings. Do you obsess about your food? And when we look at the actual stages of food addiction, I mean, craving is probably the biggest one for any addiction because it can show that a person can be a food addict and still be thin and actually not eating that much. But if they're obsessed and their whole life is revolving around food, you know, to the point where I'm eating my meal and I'm now thinking about lunch. And now I'm thinking about dinner, and I'm still eating lunch. And what am I going to do between now and dinner? And okay, I'll have a muffin in between. Like, you actually map out just like you would your drinking or your cigarettes or whatever. That same kind of obsessional piece happens, even if you're not giving in to actually eating. In fact, I'm going to show this slide in a minute, but statistics using this Yale scale indicate that about, like I said, 5 to 10% of the normal population are food addicts. Of the thin population, what we might say are, well, there's no problem, they're thin, they're not overeating, 10% more, slightly more than the normal. And then in the obese population, about 30 to 40%. But not everybody. There is certainly, the people who advocate food addiction will say a person could have not a food addiction, but a binge eating disorder or another eating disorder, bulimia, or they could have both. So, I mean, it does not exclude that diagnosis. It could actually be both or one or the other. I think I didn't finish that. The last thing, yeah, and then D, denial, diminishing. I'm not really eating that much. I know I am, but no, I'll wait until I'm insulin-dependent diabetic instead of just diet-dependent diabetic. Then I'll stop. That sort of thing. And emotional response. This is like when your best friend is your food. And, we see people at later stages, their life revolves around eating to the point where, you have plans for the night, they're canceled, good. I will have my chips and movie. That's okay, we can all do that. But if that becomes your life, so that no relationships, friendships get dropped, you don't see family anymore because they're always critical of you, you don't bother seeing the doctor because you know what they're going to say, you end up basically becoming, I've seen this, people becoming shut-ins with just their food and their TV. And it can go to that extent. What is actually food addiction? So I'm going to talk a little bit about the theory here. Why I want to say here's the conceptual logic that makes a lot of sense. We have a normal dietary hormonal regulatory system, which you can learn about at the conference or know about, that talks about the various hormones, ghrelin, leptin, insulin, our hunger hormones, satiety hormones. When my insulin drops, I get hungry, irritably so. Because my sugar is dropping, and if it were to drop too low, I could die. So it makes a lot of sense to start getting panicky and irritable when the waiter doesn't come. Hurry up, I'm hungry. It's that kind of agitated hunger is actually a sign of insulin. Ghrelin, your stomach is gurgling, you're starting to get hungry. It's all a perfect system because it makes me want to eat. And then when I've eaten, the leptin is released about 20 minutes later, the fat cells, the stomach cells, to say, okay, Vera, you're satisfied, good. And this is a great system. On top of that, this is normal behavior now, not food addiction. On top of that, we have the reward pathway in the brain, the motivating neurochemicals like dopamine, for example, that make me want to do things. And I can be hungry, but I have a cold, and when you have a cold, you can't taste the food, you don't really want to eat, you force yourself to eat. That wanting to eat when you're hungry, which is a sign of health, is actually the sign of the reward pathway adding on top of the hormonal pathway. Because that is the thing that motivates me to, I'm looking for it, I'm preparing my food and I'm starting to get excited and salivate and this is going to be good. That's all dopamine, and that's going to urge me to go to the effort of getting the food. It's my motivation, my pleasure of eating. The hormonal ghrelin, leptin, insulin make me hungry. This one makes me want to eat. So it's been built for food. The reward pathway, and those neurochemicals are dopamine, serotonin, and endorphins. Those are just three of them, but they're the big ones. And one of the things I want to suggest, and I have addicts telling me this all the time, here's why food addiction, if you acknowledge that it exists, well, actually, I forgot to tell you that what is food addiction in relation to this normal. I was just telling you normal. Normal is when the checks and balances of this system, which is perfect, are overwhelmed. So when I am hungry, my ghrelin, insulin go up, and so does my dopamine. Therefore, I'm salivating, looking forward to food. I eat. The leptin kicks in, and I have then achieved those neurochemicals that make me feel, at a certain point, when I've eaten enough, the neurochemicals are sated. Leptin actually suppresses dopamine, so the food is not as pleasurable anymore. I'm eating, but I'm full, so it's not that good anymore. And so it's a nice normal ecosystem of checks and balances. You're hungry and you want to eat when you're hungry, and then when you're full, you're satisfied because you got the neurochemical and you're good. What happens with food addiction is you give an abundance of something so that that normal checks and balances is overwhelmed by basically one item, usually dopamine, that is larger, so that even when there's a I'm full, stop, I actually don't want anymore, you still want. And I just want to urge to you to understand what the concept of dopamine feels like, because here's how you can understand any addiction. It's a want. You open up the fridge, what do I want? Oh, I want that. Oh, that looks good. That's dopamine. Dopamine is that I'm excited, thrilled, I'm looking forward to, I'm really enjoying this feeling. When that gets bigger, the food addict will say, I want more, even though I am so full, I'm groaning on the floor, or I'm throwing up, and I still want. It's like an itch. And when you scratch an itch, it feels great, even though it hurts maybe after a while, but you still scratch, you still want. That's what dopamine feels like. It's like histamine in the skin, dopamine in the brain. It's almost like that. And so a food addiction is when this overpowers our natural ecosystem. And for some people, we can be fine. Like, you know, you have a few cookies out there and you might have a little bit more than you want, but you're good. For a vulnerable person whose reward pathway dopamine receptors are already battered because of either previous drug use or genetics, this could be a shoo-in for a problem. And as I was saying a minute ago, one of the things about food addiction, I want to argue that it's actually more addictive. We're saying, look, you know, it's as addictive as cocaine, let's take it seriously. I want to suggest it's actually more addictive. In my book, I have the case of a man who was a crystal meth addict, quit crystal meth with sugar, and gained a ton of weight, then basically took the same strategy, this is a drug, I'm going to stop it, and he said that quitting sugar was harder to him than quitting crystal meth. And crystal meth, I can guarantee you, is probably right today the scariest of drugs that we have on the street. I mean, I don't like alcohol, I don't like cocaine, I don't like marijuana, I don't like the effects, but crystal meth, when I see a patient, I go, oh, I really hope they're committed to recovery, because this is a hard one. And I want to suggest to you that for some people, food, sugar particularly, can be as addictive, because we're dealing with a reward pathway that was built for food. It was not built for crystal meth or cocaine. But crystal meth and cocaine give an excess of dopamine. So indirectly, directly, I mean, it has hijacked a system not made for it, but looks closely enough that it can work. But when we're talking about food, we're talking about a system that was built for food. And so I think that's why when you give an overabundance of that, you have a stickier addiction. A stickier one. I just like that word sticky because it just works. You know, you try to pull from it and you stick back onto it because it's built for that. So it's an overabundance. And for some people, that means that they can't say no. No would work in a normal system of this that I'm talking about, but for somebody who's vulnerable, it doesn't work anymore. Okay. This is just to show you how complicated things are. I mean, when we're talking about obesity and the understanding of overeating, it's getting ever more complex. So just to say very quickly, the blue are They're the hormonal pathways, and the red are the reward pathways, and it's all very interconnected. But you have one that overthrows, it's like it overthrows the ecosystem, and that's what's happened. Just to show you an example of a hormonal, I just like this slide. This is an example of a rat that is immune to the effects of leptin, the obese rat, so therefore does not get the satiety, I'm full syndrome. And we were thinking at some point, medication-wise, well, wouldn't it be good if we could just get a leptin drug? That way the person feels full, even when they're not. Give them a drug, makes them feel full. And what we found is with obesity that people actually become leptin resistant. And for those of you who are dietitians in the crowd, you're going to know this. We talk about insulin, non-insulin dependent diabetes. The person has insulin, but they are insulin resistant. So we need to give medications to help the acceptance of the insulin. So a person who's obese is often insulin resistant. They're often leptin resistant because they have a lot of leptin on board and they become resistant to it. It's like an overuse syndrome and the receptor sites are battered down. And I want to suggest that this is speculative, and I'm going to own that it's just a speculation, but it works, that we could see addiction as a dopamine 2 receptor insufficiency. So they're insulin dependent, they're insulin resistant, they're leptin resistant, and possibly even dopamine resistant. There's dopamine on board, but eventually when you overpower that system, eventually the receptor sites or the whole mechanism works so that there's a diminished response. So now I need more to feel normal. So just to suggest that that's a way that we could see dopamine. And how does a person become dopamine resistant? Genetics. And how are we doing here? Good? Okay. Genetics and overuse, previous drug use. So the people who are receptive, the people who are most likely to get an addiction to food are probably previous addicts, and also people who are have a genetic predisposition. That's all research that we're going to find. Okay, so I just talked about that. This is the reward pathway piece. I'm not going to elaborate on that because I have to watch the time. But just to tell you that there is a reward pathway that is overtaken, and that's the piece. When food becomes energy dense, we are primed, every one of us, to desire a sweet or fatty food because it is energy dense and the dopamine is high so that I eat that food because it makes sense to my body. You know, it's the idea of a famine. You don't eat now because you don't know what it's going to be like tomorrow. And for people who are dopamine 2 resistant, they might be impacted by this. Okay, I'm just going to jump ahead. Just to give you a little bit of a flavor of what foods are, these are not necessarily addictive foods because when they are contained within a normal food plan, the FNYs, is it the FNVs, that's right. The foods that we grow are nicely contained so that if you eat sugar from an apple, yes, it's fructose, yes, it's sucrose, but there is so much fiber and the system itself is engineered so that there's only so much that I'll eat. So even if I want to eat a lot of apple, I won't because there's so much fiber and I won't get the same impact. But when you take away the protective elements of these substances, that's when you get the toxic effect. We would not be nicotine addicts if we were still just chewing tobacco from, the chewing leaves of years ago. It's the fact that we're smoking it. It goes to the brain quickly, you get high potency, overwhelms that reward pathway so that I can't say no. Same with food. If it were, a little bit of honey from a bee hive, if I stick my finger in there, I'm not going to be in there for very long to get that honey. I'm only going to get a little bit. I can handle that. But when I take away the bees, take away the bark, take away the fiber, now I've got a potent substance that's not any different than cocaine, from cocoa leaves to snorting it or injecting it. That's the piece that makes something addictive. Okay, so serotonin, we know, releases warm milk. It's a sleepy, happy, contented feeling. We know that when we eat pasta, potatoes, bananas, turkey, sometimes we eat them for that purpose. Dopamine, sugar, white starches. Endorphins, chocolate, sugar, dairy, spices. Now the research, I'm going to just jump quickly here. Let me just say this because this is fun. The Yale Food Inventory, like I said, it's our one standardized tool, actually just came out with a study a couple of weeks ago saying here are the 10 most, well actually out of 35 foods tested, here are the most addictive ones. And not surprisingly, chocolate is number one. I'm just going to jump ahead because you'll see that. The science of food addiction, like I said, we are in an anecdotal stage with some research bits here and there. We see the genetics, the dopamine 2 receptors, SPECT scans. We are largely at the level of research with rats who have, we found rats that have shown that they prefer saccharin or cocaine, or pardon me, sugar over cocaine. The researcher who did that, Dr. Avina, is actually quite a prominent speaker in the US talking about food addiction. And then the Yale Food Center. Okay. So there is some research to kind of support that there is a dopamine connection. Just jump ahead. Here we can see dopamine 2 receptors. The top one is on the one side is control, and the other side is methamphetamine. As I said, one of the worst ones. Underneath obese, you can see the dopamine 2 receptors are similarly subdued. That could be environmental. The more a person becomes, their body mass index increases, the less dopamine 2 receptor response there is. Now, we don't know, is that because of overuse of eating? Is that the weight itself? Who knows what that is, but it's an interesting finding that we're working with. We know that there's a genetic piece with dopamine 2 receptors in alcoholism and food. So there's pieces here and there that we're working with. Okay, I'm just going to jump ahead because I want to end here. Clinically, we're working with, like I said, this is not a fully recognized condition. We work in the field, recognizing there's early, middle, late stages. We tend to see the late and final stages, those shut-ins or the people who are using drugs instead of food to control their food addiction. But there's many stages. And this is just giving you some if you're interested in that. I have a little bit of discussion, which I'm not going to bring up here today, about how medications for obesity might be helpful for the people who are not food addicts, but for food addicts, they could actually be dangerous. Vyvanse, the very exciting drug that was mentioned just a couple of weeks ago, is being touted as the new obesity drug. That's going to be bad news for food addicts because of the high abuse potential of Vyvanse. The treatment is, this is really the bottom line of what I want to say, or sort of coming close to ending here, is that the reason why it's so important to acknowledge food addiction as its own separate condition is because it calls for a different treatment. And the predominant medical response to obesity and eating disorders has been a little bit of what I heard earlier, a kind of moderate eating plan, eat well, learn how to manage portion sizes, and choose your portions and whatnot, but still eat everything, just in moderation. And with food addiction, we would say, no, 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 no. If you are actually a food addict and you have decided or found that this is something you're addicted to, it becomes a chemical that irritates. We call it an allergy. It's not an allergy. It's a hypersensitivity. When I eat this thing, oh, I want more, and I can't stop, and yes, I want to stop, but I can't, and that whole obsessional thinking starts. The best way to deal with that, so that you have peace of mind, figure out the substance and then stop eating it. Simple, not easy. Because we don't have a system that has professionally embraced this concept, we can't support long-term recovery. In addiction, we say the first step as you walk in the door is quit the substance, but that doesn't mean you're out. We have 3 weeks of program, and then we've got a year of continuing care, and then we've got 12-step programs. Why do we have to do all that? Because the brain wants to, once it's found its golden grail, the default mode is to go back there again. And relapse prevention becomes crucial. So that's why the diagnosis is important. So I'm going to end here by saying that there's a message of hope here. not only do we not have to have an entirely resigned, compassionate view about weight and people's struggles with food, there may actually be something that we've been missing that acknowledges that there's this overpowering dynamic that is aided by the food industry, but even so, you can do it yourself. And if we can just acknowledge that dynamic as what it is, we might be able to offer not only a diet plan or treatment plan that will be sustainable, but also peace of mind. Because how many people talk about, they go on their FNW, or Hawaii's, I'm sorry, vegetables. Yes, thank you. But they can't stand it. They're still wanting, and it's that white knuckling, and it's the diet keeps failing. Well, maybe it's because along with their fruits and vegetables, they're putting a little bit of honey, and that's the thing that's making them want to go back. So we want to eat these foods, but it's actually possible to eliminate that obsession, and then the consequence of that is often weight stabilization, if not weight loss. And that's a message of hope for people as opposed to resignation. Okay, I'll leave it at that, and if you have questions, I'd love to take them. Thank you. Okay.
Thank you so much, Dr. Tarman. A couple of really quick comments just as a dietitian who's enjoyed her entire book. What was most convincing for me when I read her book, she's mentioning different case studies and very heartbreaking ones, a lot of them. And several of them mentioned how the eating disorder system is failing individuals with food addictions because it only is treating the underlying emotional things, which is not the key concern for these individuals. And as soon as we go back to our message of all foods can fit, eat all these foods again, they're triggered and they're back on the bandwagon. So these are new ideas for many of us. The more you get through her book, the more and more convinced that you become that actually completely avoiding certain foods may be the best way for some people to try and go. So I've found that extremely helpful for myself, and I really do recommend anyone pick up the book. You will definitely get something out of it no matter what area you work in. So now questions should be, yes, we can go ahead on that one first.
I'm just wondering what your thoughts are, this side.
Okay.
What your thoughts on the possible role of deprivation in food addiction, as it's a big issue with eating disorders, and I'm trying to sort of separate what you're saying, and quite honestly, I've never been a real fan of the food addiction model for a number of reasons, but whether the role of deprivation, whether it's physical or just setting up foods as good and bad, so it's more of a psychological deprivation, might play in the concept of food addiction.
I think that's a great comment, and yes, you're right, that is the danger that we're playing with. So if a person is not a food addict, it's why I would say make it a suggestion, and clinically I would say, okay, if everything else has failed, let's do a 3-month trial and see if it works. Because the goal is, at the end of the day, certainly not in the first month, because you have withdrawal. Like, there is actually withdrawal, which might just be, I'm insanely wanting that bagel that I always have and I can't have now. And yes, there's an element of deprivation, but what happens with addiction is just like a person who's quitting a drug. They feel deprived. But if they are addicts, after about 3 weeks or a month of stabilizing, basically removing the hijacker, the feeling of deprivation is gone. I'm actually okay with just eating whatever it is that I'm eating. But there is a danger, you're right, between making some foods enemies and the deprivation syndrome. You can't have it, you just want it. Like that's true. Addicts have to go through that all the time. They get very jealous. This guy at the patio gets to drink and I don't, and that's not fair. Yeah, it's not fair.